And we have a few administrative items to cover here at the beginning for folks who have not joined us before, and just as friendly reminders. We do record these calls, so all of you have been muted as you have come into the call so we can avoid background noise. And those recordings are posted on our Confluence wiki along with the slide deck that you are seeing here. And we will also follow up with an email after the meeting. And we appreciate your patience. It was a busy week last week and a short week this week. So hopefully most of you received our reminder email and follow-up from last week. While we are presenting and during the Q&A sessions, you are more than welcome to pose questions and comments using the chat feature. And if you do so, please send it to everyone, because that allows my entire team to see everything that everybody is submitting. And that way we can hopefully catch all of your questions and comments as they fly by so quickly. We've had some very spirited discussion in the past meetings, and we really appreciate all of your input and your comments. If there's anything that we cannot address during the call, you can either reach out to us via email or we will reach out to you. You can email either me, Lynette.Elliott, or you can email gravityproject@emiadvisors.com. Next slide, please. We encourage you, if you have not already done so, to go ahead and join the project as either a committed member or an other interested party. And committed members are expected to provide input and vote on project documentation and deliverables. And other interested parties can participate at whatever level they are able. You're not obligated to vote. You're not obligated to provide input. Actually, there's not an obligation for neither one, but committed members can vote. And we do appreciate you signing up as a member, because this is how we are tracking our members and being able to reach out to you all via email for communications for follow-ups. And anytime there might be a schedule change in these upcoming months, because we will encounter holidays during the summer and during the fall and winter. So we may have to move some things around at some point. If you're not sure whether you've signed up already, you can check that on the wiki as well. And there's also any other information that you would like to find for the Gravity Project. Next slide, please. Today we will be covering we'll recap the schedule, the upcoming work group schedule, so you have a good idea of what we will be discussing in the upcoming weeks. We will recap the use case package components. For those of you who might not have been able to join the call in the past couple of weeks, that will be a refresher for everyone else. And then Evelyn will take you through a deeper look at patient story 1, as well as use case narratives. And then we will take some time to answer questions and address comments. And then I will show you some updates that we've made to our Confluence wiki so that it's easier for you all to find things. And so we can post the materials that Evelyn will be showing you today so that you can review those and provide feedback. And then we will adjourn with next steps. Next slide, please. And then at this point, I will hand it over to Evelyn Gallego, who will walk you through the goals and the presentation. Evelyn?
Thank you. Yep, thank you, Lynette. Good afternoon, everyone, and thank you all also for coming back. We want to thank those that have been very good about joining us on a week-by-week basis. And so you'll see that we have a pattern, establish a way that we start these meetings and proceed on walking through our content. So as I've done for the last couple of sessions, as we've done as a team, we have goals. So today, our goals for the session is to recap what we talked through last week, where we introduced what we mean by use case and our approach for developing the use case package. And then we'll do a deeper dive on this patient story 1, which is an illustrative story of the personas we introduced last week, interacting with each other and the health system as they document and share coded social determinants of health data. And I'll also walk through the use case narratives, which are the interactions between these personas and the systems they use. So here's a recap of our schedule and activities to date. Again, we've been using the same slide over the last couple of weeks. We are at week 5. We are where we're building on what we presented last week, which again is the personas, patient stories, and use cases. And then last week, we also introduced our timeline for the coming weeks, coming month. We're scheduled to walk through these use case package components. So this, is what you see here on the third column, the assumptions, pre-post conditions, actors and roles, base flow activity diagrams, and so forth. This is what we refer to as use case package components. We'll be reviewing these week by week until we get to the end-to-end review scheduled for June, end of June. And then our target date, so the next big stretch of work is kicking off our food insecurity work group on July 18th. So I do want to take some time to thank those who have sent us their data elements using the data elements submission template. We are starting to review, consolidate these submissions, and we'll use that information to inform an initial data set to review with all of you as part of that July 18th meeting. And as a reminder, as I mentioned last week, this schedule is not set in stone. We want to be agile as we work through these tasks week by week while keeping focus on the goals of our project and our timeline. Okay, so last week we spent some time walking through what we mean by use case, and we're bringing it back again because I appreciate it may not be clear right up front why we need to create use cases when we're focused on defining codes for social determinants of health data concepts. So I want to restate that the use cases set the foundation for standards efforts. Although they are designed to be standards agnostic, they provide the requirements needed to determine what standards can be used or what new standards need to be developed to support the transactions. Use cases will help us describe the operational context for documenting, sharing, and exchanging social determinants of health data. And we don't want to create we just don't want to create coded data sets. I know this is a coding collaborative. We want to create them knowing how they will fit into existing clinical operations, and that's why we have use cases. Last week, we also introduced these three key components of a use case and spent more time on the personas. Today, we'll spend more time on the patient story and the use cases. We'll go through these quickly. Okay, so the patient story I'll walk through today is based on the interactions between these 5 personas. Some of these personas are further described in the persona template we posted on the Confluence on our Confluence page that's available through this link showing here. We did receive feedback, so thank you to, we got lots of feedback last week on what additional fields to add to these personas. We're currently working on making those updates, but I want to acknowledge the personas are meant to be snapshots. They're snapshot of fictional characters and who are impacted, so we'd say who are impacted by the documentation of coded social risk factors in clinical settings. They are not meant to capture all the data components of an individual or persona. They are summaries of that persona's current situation, needs, and preferences that really are, that we have put together to inform how we develop the standards. We also created this Gravity Personas page on the Confluence side because, as I said last week, we want to develop an inventory of personas that can not only be used for this project, but for any other social determinants of health related initiatives that are developing a service, product, technology, or even a policy. So we do want them to extend beyond just our scope of work. So today we'll introduce, as I said, this patient story, one that includes these 5 personas interacting within 2 settings. So some of the activities will be Rebecca's home, and actually we'll talk about her doing some activities within her, at her workplace. And they really emphasize these 4 clinical activities. As we're working through, we really need to have key activities that illustrate what would be documented and shared across screening, diagnosis, planning, and treatment activities. The patient story will inform these 3 priority use cases. And again, I introduced these last week, but as I walk through this patient story, I want you to keep in mind these 3 use cases, which surmount to how data is documented and shared across different systems to inform care delivery care delivered, and other upstream activities. So we'll talk about what those will be when we get to the deeper dive on use case 3. Okay, so I'm going to, I realized as we were trying to figure out how to share this patient story with you, we have to sort of take a step back and think about what are these considerations around assumptions, preconditions, and postconditions. These topic areas are actually slated for next week, so I will be introducing these concepts deeper dive next week. But I wanted to quickly introduce them now because I anticipate as you're listening to the patient story, you're going to have questions and comments regarding some of these concepts, assumptions, as you hear the story. So for now, again, this is not all-inclusive. We'll spend more time, so it's also a heads up for what we will be discussing next week. But we have to come up with a list of assumptions. We have to come up with a list of preconditions and postconditions. So for now, as we walk through this patient story, let's assume the patient is insured. We will not state in the story what type of insurance she has, although we can, but right now we have not. But she has some insurance, which allows her to access health care. And we are assuming that she can access health care and can make a wellness appointment and has given consent to share her data. The preconditions are really important here because they specify what must be in place from a systems perspective to support the interoperable data sharing. In our case, our primary precondition is that the EHR has the capability to document coded social risk factors across those 4 clinical activities of screening, diagnosis, treatment, planning. Sorry, I meant to include planning there, treatment, and interventions. Postconditions describe the state of the system that will result after the execution of a process, activity, or task, such as the ability of the EHR to aggregate the coded SDH data and generate reports. So again, we will not spend time on these today. We'll spend time on these next week, and I just want you to consider these as I walk through the narrative. I also want to remind our participants today that our overarching goal with this project is defining coded social determinants of health concepts. And the use case is set up to describe how a system or how the system should perform to support that coded SDH documentation. It is not on how it will be built or implemented. So we're not looking at that. We're also not spending specific time on the exchange. We say we want to code it to be able to exchange it, but the use cases are not around moving data across different systems. They are geared, focused on the documentation so that they can be shared for multiple purposes. Actually, let me go back because I don't want to scare you all. Before I get to the patient story, I want to acknowledge you're going to see a lot of text on the slide. The patient stories are described, actually, we did put them together as narratives, so they are a story, but it's really hard for us to toggle between the Word document and the PowerPoint. So we decided to pull out the components of the patient story and present them in bullet form so you can visualize the actions across a timeline. So as I move over to patient story 1, lots of bullets here. So I ask you to bear with me as I walk through the story. I will emphasize certain points, but again, it's really to think of it as a longitudinal timeline, and I apologize for all the text. So let's take a step back. That we are building this patient story around Rebecca, the persona of Rebecca, again, presented last week, available in our persona in the Excel sheet on our wiki. And so in that persona, we have a story around her that, you know, it notes that she was recently separated, living on one salary while caring for 3 children under the age of 6. She can barely pay for rent and depends on public transportation to travel to work. Although she is employed full-time, she is struggling to make ends meet while also addressing her asthma condition. So our story starts with Rebecca making an appointment for an annual well visit with her primary care provider, Dr. Carla Sanchez. While waiting to see Dr. Sanchez in the exam room, Samir, one of Dr. Sanchez's clinical staff members, collects Rebecca's vital signs and asks Rebecca to answer a few questions from a social risk screening tool the practice is using. Samir explained that Dr. Sanchez's practice is screening all patients as part of their annual well visit exam. Samir provides Rebecca with a mobile tablet with the electronic questionnaire. Rebecca answers the questions and returns the tablet to Samir. Samir uploads the completed questionnaire into the EHR. Dr. Sanchez enters the exam room and begins the consult, inquiring how Rebecca has been since their last visit. Rebecca shares her story about the significant life changes, including separation from her husband. She tells the doctor she feels overwhelmed and guilty, that she comes home too tired to do anything but get the children fed and ready for the next day. Dr. Sanchez uses her EHR to review the results of the social risk screening and past history for Rebecca. She examines Rebecca and notes Rebecca is overweight and her asthma is worse. Rebecca acknowledges she saves money by buying low-cost foods such as macaroni and cheese and pizza, and she rarely buys fruits or vegetables because they are more expensive. Rebecca cannot always afford medications, so spaces out her asthma controller medication to every other day instead of every day. Continuing with the story, so Dr. Sanchez inquires whether Rebecca has talked to her landlord about mold or another allergen remediation. Rebecca confirms she has not. Dr. Sanchez tells Rebecca the screening responses indicate distinct risks around food insecurity, housing instability and quality, and transportation access. Rebecca confirms these are 3 areas she needs help with. To address the asthma concern, Dr. Sanchez and Rebecca identify, so together, they identify goals to reduce the asthma triggers in the home and minimize the cost of the medication. Dr. Sanchez reviews the cost of Rebecca's asthma controller medication and determines or finds that an equally effective lower cost medication is available. She also confirms Rebecca is eligible to receive an asthma home visit and therefore places an order for new asthma medication and submits an electronic request for an asthma home visit to assess the asthma triggers. Okay, moving on with the story. So now to address the social risk factors. So the previous were around the health concerns. Dr. Sanchez and Rebecca then identified goals, again, together to address the social risk factors. And the 2 goals are 1, to find more affordable housing solutions and healthier food options, and 2, to find more efficient transportation options. They discussed an action plan to address the goals that involves Rebecca working with a care coordinator to identify and secure available services and supports. Dr. Sanchez then refers Rebecca to her practice's care coordinator, Riza Shah. So this is the 4th persona, Riza Shah, who can help connect Rebecca to available resources, either those available in-house or those available in the community. So in this case, just as a side note, we understand that some services are available in-house while others need to be found outside. So Riza can help assess Rebecca's eligibility for SNAP benefits and WIC services. Dr. Sanchez then documents the agreed upon health concerns, patient goals, action plan, and referral in the care plan within the EHR. Samir then returns to the exam room and works with Rebecca to find another date time to schedule a telephone consultation with Riza. Samir schedules the appointment with Riza for the following week and a follow-up appointment with Dr. Sanchez within 3 months of the appointment with Riza. So they're scheduling that all together. Okay, continuing on. So the following week, Rebecca, so I'll summarize these quickly, lots of points here. The following week, Rebecca meets with Riza over the phone. Riza has already reviewed Rebecca's care plan and has identified resources to support the care plan goals. Riza walks Rebecca through because they're in San Francisco, so she walks through the California SNAP eligibility enrollment process. Riza determines Rebecca is eligible for SNAP benefits and encourages Rebecca to complete the SNAP application either online or by visiting the local SNAP office. Rebecca completes and submits the online application the next day during one of her work breaks. Again, assuming this is another setting, she completes it outside of the clinical setting. Riza contacts Rebecca within 1 week of their initial consultation. Rebecca confirms she submitted the application. So again, the only way, so again, I'll pause here from that story. Riza has no way of knowing whether Rebecca met the identified intervention. Or the referral out. So she has to call her, and then that's why we're assuming, again, in a perfect world, there could be a way to have the systems interact, or Rebecca submit this confirmation electronically. But in our story, we are assuming Riza will conduct the outreach and confirm whether Rebecca submitted the application. And in our story, she does confirm that Rebecca did complete the application online, and so Riza then is in charge of updating the EHR with that action. Within 2 weeks, Rebecca receives an email confirmation that her application has been approved. This is for SNAP benefits. And then Rebecca begins to receive SNAP benefits 1 month later. I expect it could take a little longer, but in our case, we're assuming it takes within a month. Okay, so moving on to the next scene of the story, and we're almost done, so thank you everyone, please bear with me. Now we introduce Michael Frank, the fifth persona or actor, as we'll be calling them actors, who is the asthma home visit provider. So he contacts Rebecca by phone to schedule the asthma site visit. Again, the assumption is that he's received that request from Dr. Sanchez and is acting on it. So Michael then goes out and conducts the assessment at Rebecca's home and discovers there is a slight mold in the apartment that is aggravating Rebecca's asthma. Michael then emails Rebecca, Dr. Sanchez, and Riza a copy of the home visit report and recommends Rebecca be referred to a housing coordinator, to a housing coordinator. Riza then reviews, so we're assuming, again, the care coordinator is the one that reviews this report. So she reviews Michael's report and uploads it into the EHR. Within 1 week, Riza emails Rebecca with the names of 2 housing coordinators. Again, Riza is taking action on the recommendations of Michael. Rebecca then meets with Dr. Sanchez for her 3-month appointment or follow-up appointment, where Dr. Sanchez then discusses Michael's home visit report results with Rebecca, and Rebecca confirms she is receiving SNAP benefits. Dr. Sanchez then updates Rebecca's care plan in the EHR. Lots of activities. We know this story can go many ways. And we can continue. So this is the end of our short patient story before we get into the use cases. But it's acknowledging, we have a story, we have a series of events that happen across a timeline. We have personas interacting with each other. We have data being documented in the EHR. And we have actions being updated, completion of those actions and interventions being updated in the EHR. So we want to emphasize that as part of this story. So now we're going to switch to our use cases. And what you'll see here is how we are taking these use cases, which I described at a high level last week, and we're taking the patient story I just walked through and trying to describe it in terms of these 3 use cases. Now you'll see that the narrative, so we no longer are referring to them as personas. The narratives are described in terms of the actors and roles, so not the individuals or the persona. So in that case, Rebecca now becomes the patient. Dr. Sanchez is the primary care physician, or PCP. Samir is the clinical staff member. Riza is the care coordinator. So we give them different, again, we describe them in terms of their roles. These narratives focus specifically on the action of these actors and the interactions between the actors. And when we talk about actors, I talked about human actors, but the other actors are also the system actors, which is the EHR, or any other system that is used to document and share data or aggregate data. And we also have business actors. In this case, although we haven't called it out, the business actor, one of them would be Dr. Sanchez's office. So as a primary care practice, it then serves as an actor. And we'll go through what we mean by actors next week. But again, we want to create the use cases that describe them in generic terms. So this first use case is about documented the coded social determinants of health data as part of a patient encounter. So the patient, so you'll see this is now, and I'll go through all of these, but not as in much detail because we've already talked about the patient story. It's just showing what are the steps involved and then how we would then take this, because when we talk about the use case package and we look at the diagrams, the sequences, they would be focused on these use cases, not the patient story. So it's the interactions between all these actors. So just to start, this here we have the patient. So again, the story building off Rebecca, patient visits their PCP for annual well visit. They can be, again, visiting for any visit, but in this case, it's an annual visit, and completes an electronic questionnaire on a mobile tablet. The clinical staff member uploads that into the EHR. PCP reviews the results in the EHR, and the PCP records patient would like, or documents that the patient would like assistance with the social risk factors identified. So again, sequence of events, very simple. Moving on to the second use case. So this second use case is about documenting actions taken in response to the identified needs. So in this case, the PCP uses the results from the screening and the examination to engage with the patient in developing a care plan. Both actors identify goals, interventions to address the goals, and the actions the PCP and patient will take to achieve the goals. So when I talk about these, again, these are very standard care plan activities. When it's part of the care plan process, you have to identify your health concerns, your goals, and what interventions you'll identify to address those goals. So again, and action. So these are very much in line with the care planning process. These activities are documented in the EHR care plan. The PCP submits a new order and an electronic request for an intervention. And using Rebecca's patient story, the order is for a new cost asthma medication, and the intervention is an asthma home visit. We added these here in italics for context, but for other patient stories, these could be other orders or interventions. So keep that in mind as we discuss these. You'll see things in italics because we do want this to apply to multiple patient stories, so they could be related. So also noting here is that the PCP documents the other priority intervention as a referral to the care coordinator. So moving on with Rebecca's story, and again, this is use case 2. We've talked about these activities here. Again, you see the actors, in our interest of time, and probably get tired of hearing my voice. It's really around the actions, again, building off very much the story. These activities relate to the care coordinator meeting with the patient, coordinating the referral, and documenting the activities in the EHR. And then moving on to the second phase of the timeline, this is around then Rebecca returning to see the PCP, as part of the follow-up appointment, the PCP updating the EHR based on the status of the referral and the outcomes of the intervention. Again, the referral, interventions, and outcomes are listed here as examples, and that's why they're in italics. So move on to our last use case, which is reflective of activities that are initiated as a result of the first 2 use cases. So this use case 3 is dependent on use case 1 and use case 2. These, what I'm going to be these are not discussed in Rebecca's patient story because they're not about her directly. It's not her timeline, but we could add them if it's as we introduce other personas. But it's really, we have the patient story around one individual and following their progression and interaction with the health system. And then this use case is really dependent, like I said, on the other ones, dependent on the data. So we've come up with what we call three overarching activities, and we've grouped them under population health management, quality reporting, and risk stratification and risk adjustment. These are not inclusive. The EHR system transactions can be similar because, again, it's really around aggregating the coded, documented data, and then to support these various activities. So starting with the population health management, again, just to illustrate, in this case, we can have an actor. It could be a clinical manager. It could be, you know, we didn't call out who it would be, but it would be an actor who would review the EHR data monthly, focused on identifying data specific to social needs and related referrals. The clinical manager in this case notes that the EHR data indicates one social risk factor is more frequently reported in their patient population. The data also shows the social risk factor is rarely reduced with referral. So again, the EHR must provide that capability, but it can only do so in a unified manner if the data is coded, standardized. So the last step here in italics indicates the clinical manager will act on this data. Since this action is more process related and does not necessarily involve the documentation and sharing of coded data, I have left it in italics only for context. Again, always thinking of what we're going to create in our use case diagrams. We're not going to create a, you know, this would be like an end stop where, you know, the process ends, where clinical manager acts on the data. You know, it ends up doing some other internal process, but we're not going to document it as part of our use case, but we do want to recognize it. So moving on to the second example here in regards to quality reporting. So here we have the clinical, again, we could keep the same actor, but we're acknowledging the business actor, the business, the Dr. Sanchez practice. They are located in a state that requires, so in this case, the state requires providers to identify social risk factors among Medicaid patients, at least annually, and to refer the patients with risk to appropriate resources. In this use case, the clinical manager actor uses the EHR to generate quarterly reports that list the total number of patients screened and the total number of screened patients referred to services. Clinical manager then submits the reports electronically to the payer on an annual basis. So again, we're not noting any actions taken on the data. It's the capability of the EHR system to aggregate this coded data and report it out for other, in this case, it is for quality reporting. And we're almost done, and I see comments coming up. So last, please bear with me, and we're on time. The last slide here we have is the last use case around risk adjustment and risk stratification. In this case, the clinical manager, again, we're not, it could be another actor, uses the coded SDH data within the EHR to generate reports that are sent to the payer. So again, this could be any payer. The payer then has actions around the data, as we see here left in italics, because that is out of scope for our project. In working through this, the previous one was quality reporting. We assumed the EHR could generate, aggregate the data and generate a report. In this case, what we have is a question, because I did have this personally, I did not understand if this is happening right now or it could happen. But the last thing I leave you with, and then we'll open up with questions, is right now, do we have primary care practice that send reports to payers or send claims that incorporate coded SDH concepts? So it's really, I want to get the truth around what is really happening and then put this in the context. So I will stop there. That ends my presentation for today, and we have lots of time for discussion. So Lynette, I will ask you to open up the line and let me know what is happening. Oh, the answer is no. Okay, great.
And Seth Blumenthal indicated that it could, sometimes either or, depending on the provider.
Okay.
And he is clarifying if it's part of a payer-driven program, providers may be required to code that and send it.
Okay, good. All right.
That's helpful.
Yeah, that is helpful. Okay, go ahead.
And we had a comment first from Maria Moen saying she would like to suggest that we expand the patient persona to provide an opportunity to look at social determinants of health from 3 perspectives, because they differ greatly and could impact the fit across populations. She's suggesting young patients between the age of 10 and 20 years old, an adult patient, say 21 to 49 years old, and older patients, possibly 50 plus years old, because their experiences and needs can vary greatly. And Maria, if you want to add to that, you can jump on the line and comment.
As Maria comes in, I do want to acknowledge we do have, last week I had announced the AMA and UHC are working on a patient story right now, and theirs is 65. And we do have that persona already listed. We have an older gentleman, Saul, identified, because we do recognize we need to have different ages. And we also have, that's the reason we also have Rebecca with 3 children under the age of 6, because we also have someone younger, you know, middle age and then older, but we do want to have, we hear you. So we welcome you to add to Saul's patient story as well, a persona.
Yes, and we would look to all of you to provide feedback on what we have already defined here and comments. So we can add, subtract, make less, make more, make different. So that's what we're going to be asking you to do for homework. We have another comment from Jessica Ricardo regarding your work group question. She says, as a payer, I can say that we are currently not receiving or exchanging the social determinants of health with PCPs. So that was just clarification. It was your question at the bottom of the slide here. She was responding to that.
So they're not, okay.
And then Ruth Weta is asking, do the leaders of the Gravity Project want to stay with a condition specifically in mind, or will multiple comorbidities be acceptable too? Are we interested in primary prevention as well?
So the example here, the health concerns, we were leaving it open because, again, our focus is on social risk factors around food insecurity, housing instability and quality, and transportation barriers. So those are the data set requirements. So when we actually get to the data set, it will be around that. But we have lots of other data sets. But if there's a need to include a specific health concern, we could include it in the patient story. It's just not the scope of our work. We just want to recognize there will be health conditions, related health conditions.
Okay. And then George Dixon comments, payers have been requiring CCDA extracting data looking for gaps in care. A possible use case with value sets in inclusion and transfer of care documents.
George, do you want
to George, if you want to clarify that. Yeah. Sorry.
Is he on mute?
Let me unmute you, George. Let me find you in the list. Oh, you might be just, there you are. Okay, let me unmute you. George, can we hear you? There we go.
Thank you for unmuting me.
Okay.
We're seeing more, well, the data available out there for payers is the CCDA, and they're trying to use it for things that originally may not have been built for, which is great, and it's great to see it in use. But just thinking forward as a use case, and you're developing charting requirements and your value sets, do we want to push the use cases to work towards getting those in CCDA documents or with FHIR resources so they can be available?
Yes, great point, and that's why we're using the terms of goals, and we could use it's just because we know that there are standards available that can package these components.
Yeah,
exactly. Yep.
Got it.
Yep.
Thanks.
Yep.
I'm just playing straight guy.
Yeah, no, they're
and you're doing very well. Thanks, George.
Yeah.
And I was going to say if you want to go ahead and hit your own mute button, that will be wonderful. From April Joy Damien, she is asking, will there be an opportunity to discuss how to educate or orient clinical staff about screening for social determinants of health? She wants to share their data, but it came to her attention that some social determinants of health items were omitted since some clinical staff were hesitant to ask some social determinants of health related questions.
That is yes. So our scope of work, no, we are not working on process or implementation. We can point you to resources out there, but I do, and that's something we're thinking through, and that's why the story actually that's a good point. The story has Rebecca filling out the questionnaire in the mobile tablet, because that does come up that the clinical staff are not comfortable asking those questions, and there still needs to be a lot of education and training around it. So for ease of our patient story, we are assuming that the clinical practice, if they are going to adopt having all wellness visits, screen for all annual wellness visits, then they have a means to collect that data and being sensitive to both the patients not wanting to disclose information to someone face-to-face, and also the clinical staff not feeling comfortable asking the questions.
Okay. And Michelle Proser had commented on your question to the work group, saying regarding payers, she says she believes many payers are aiming to do that. So
that's why we included it.
Yeah. And
we know they are.
Yeah, and for phase one, we are very, very focused for phase one, but this work will be taken further in phases 2 and onward once it's rolled into HL7.
Yep.
So that's when those discussions will take place. And thank you all for thinking so far ahead. We're very excited to have all your bright minds on these calls. Okay, and Beth mentions, she's asking, as food security is a household issue, would the identified need transfer across linked housing members and transfer to payers based on a household versus an individual?
So that would be panel population health. So that, again, that's the activity of how that data could be aggregated. It could be at in this case, it is, our example is patient level data, but we can make it population or panel level data. So we just want to, again, the focus is really on the ability to aggregate the data quickly and report out, because it is in a coded and standardized way.
Okay. And then Lisa Bond was indicating that she agrees with April above regarding how clinical staff and care coordinators can obtain that kind of data. So that may also come up in discussions that we have about sensitive language, because there will be some discussion around non-discriminatory language while we're reviewing some of these data element concepts. So stay tuned for that. Lori Peterson says, need to separate claims transactions versus reports. Social determinants of health concepts are not billable, quote unquote, and therefore would not be part of a claim transaction. To Seth Blumenthal's point, if there is a payer-driven program that reports if there is a payer-driven program, it reports with SDH concepts may be required, but those are coded in an EHR solution that would be included in the CCDA conditions section, along with a medical diagnosis such as asthma. So I think that's a good clarification.
Yep. Yeah, and that's for us is, again, what we are not, and these could be things, again, these could be preconditions, post-conditions that really specify what is the reality of this, but we also know that we're trying to push, we always say we create this work because we know that we want to get to interoperable data exchange. So what is realistically, how should we be defining these use cases so data can, we are supporting the seamless, as we say, the seamless exchange of the data across systems. So in this case, from the EHR, being able to pull the data, documented EHR, and share it with the payers, and having the payers act on it. What's the best course? And many of them, for value-based payment, there's a lot of work going on for building off both clinical and claims-based data. So figuring out how best to do that.
Okay, thank you. And then Emma has a comment here, and she has 3 people who are agreeing with her and saying, thank you for asking. She says, not just primary care, but community-based organizations might also report SDH data to healthcare systems or payers. CBOs are becoming increasingly involved in VBP contracts, either as part of a network or alone, to address SDH. She would be interested in to know how coding needs to differ, if at all. Maybe a non-clinical use case would be helpful.
Thank you. Yes, this is our challenge that our scope of work is looking at it initial starting point within the clinical setting. We know many CBOs already do this and are required to do so for payment purposes. We wanted to address what needed to happen within a clinical setting, whether not to medicalize this, but really to think through if there's a way they can initiate or document the initial referrals out or the care coordination activities in a standardized way. The intent is, of course, we would want, if things are documented clinical setting, that they can be integrated in the community-based setting, but we can look at if this is, again, looking if the CBO is also documenting clinical or clinical health concerns, I would say health concerns, they can, again, be plugged in as we go through the use cases where the provider then becomes a clinical-based organization, and they're looking at both clinical and social risk clinical health concerns and social risk factors, if that makes sense.
Okay, thank you. And Beth, I'm going to unmute you because you are clarifying your earlier question, and I think it's probably easier if you speak to it.
Sure. I was asking about, in this case, Rebecca had food insecurity applied to her persona. And my question was about how that data is also going to be applied to other people in the household, because this isn't an individual diagnosis. It would be a family diagnosis or a household diagnosis. And when we're talking about data transferring to payers, like for value-based payment, it would be important that that code travels with the children and Rebecca herself, as that reimbursement should be applied to the whole household. Thanks.
Thank you for bringing that up. That's an excellent point. And I don't know if Lisa is on from our team, but that came up when we were thinking of Rebecca and the 3 children, because initially our persona, our patient story was around the 3 children, having one of them with the asthma and having the whole family having a food insecurity risk factor. And so we know, again, thinking through, because we are involved in the standards world, right now a standard doesn't exist and George, the standards folks chime in. I was told there is no standard within CCDA or FHIR for family. There's no way to document, but it's something that should happen, because if there is a risk, a social risk factor, it would not, at a family level, would impact the whole family, not just the individual. So there's no way right now to track that. And when we asked our siren lead, Laura Gottlieb, she said, right now she could just put it as a note that the family, but there's, things are documented at the individual patient level, and there's no way to group patient records by family. Unless, if anyone knows that, and otherwise I welcome you all to chime in, but I think that's the challenge with this case, but it's a great point. It's something we've noted. We actually said that as we move on to phase 2, we really need to think through of being able to document this at a family level, not only individual level.
And Evelyn, I will go ahead and read some of the comments that are coming in regarding this, and then we'll go back to another question that was asked really quick. Jenny Harvell is saying, it seems an underlying assumption for all use cases is the ability to accurately identify each individual or unique patient. And she's asking, is there a place to list or identify assumptions? And yes, there is. And I think that's what you were going to cover next, correct?
Yes. Yep. Next week we do assumptions. Yes. And we come, please. We will start with a list, and then we basically open it up and ask you all to either comment in, give us additional assumptions that we should be considering for these use cases.
Okay, and then from Tim Williams, he says they don't really see family relationships now, and that payers basically have to reconstruct those. And Ashley Micklethwaite is saying she thinks it's important to think of the payer as a larger pool than insurance providers. Collecting SDH is imperative, and outcome data is imperative in documenting collective community impact for continuing grant funding. And that grant funding is often the sole source of funding for some of these preventive and SDH programs. So I think that all goes back to how individuals or families are identified.
Yeah. So I think it's really important, absolutely, and we still figuring it out from a standards perspective.
Yes. Okay, and then there was a question of, oops, let me scroll back up here, and I think that we'll probably need to move on after this one. Ruth Weta was asking, some health orgs are using community health workers to collect and act upon results of SBDH screens. Would a CHW be able to document an ICD-10 code in the EHR? And the answer came back that the ICD-10 CM guidelines were updated in October of last year to include social determinants of health documentation by any clinician involved in the patient's care. So the answer is yes.
Oh, thank you.
Yes.
For confirming that.
Yes, and yeah, and thank all of you. Thank you, Donna Rugg and Caroline and Stephanie Franklin, and I think yes, I thank you all for commenting on that. We appreciate it. And I think we are at a conversational lull in the chat. So if you want to go ahead, Evelyn, I think we should probably.
Okay. Does anybody? Yeah, just because we. Oh, that's right. Any other questions before I jump off to the next slide? Okay. Oh, sorry, I meant to be. All right. Okay, Lynette, do you want me to toggle into right
that would
now?
Be wonderful.
Lynette,
sure.
Okay. Sorry. Let me
sure.
just.
We're going to show you all. We've made some updates to the Confluence space because we are now posting, instead of just asking you in general to review existing project documentation, we are going to be asking you to review and submit feedback on the things that have been presented in the past couple of weeks, one of which is personas, another of which is user stories, and the third of which will be the use cases. So we are going to ask all of your bright minds to take a moment to look at those things if you're interested in reviewing and providing feedback. And this is the home page. Many of you have probably, no, this is not the home page. This is the Workgroup page. Many of you have probably, that's okay. Evelyn's working ahead.
Yeah. Sorry, I'm trying to get this all back. Yep.
It's
okay.
All right. It's all blue and white, so it sort of looks the same, and we apologize for that. This is the home page, and if you scroll down, and we do include a link to this in our email updates, if you scroll down on the home page, there's an upcoming workgroup meeting space, and over here on the right-hand side, we have added the homework column. And you'll see that there's a link to join the Gravity Project, if you haven't already done so, and we've talked about why you should. And then for review, we will have the personas, the patient story, and the use cases. And personas is currently linked because it goes to a separate page where the personas worksheet is living. And we are aware that there have been some download issues with that worksheet. We are working behind the scenes to fix that problem. If you're still having trouble with it at the end of today or early tomorrow, please do email us, and I will double, triple, quadruple check. But the tech team is on it right now, so we'll get that fixed. And then after this meeting, we will put links for the patient story documentation and the use cases documentation, where you can just click on these links, and it will take you to where you need to go to download those. And we've also made another update. We cleaned off all of the stuff that was behind or was underneath this schedule table. And Evelyn, if you want to scroll back up just a tiny bit. There we go. We just have a link here for the existing project documentation. So the current version of the project charter, the links to the glossary and relevant work, and all of those documents, that link will take you to this page that Evelyn is showing you here right now. And this is where all of this documentation will live. And this is on the project meeting materials page where most of you are able to access the past meeting materials. So past meeting materials are posted at the top if you want to go ahead and scroll up. And everything, all the project documentation is below. And again, we try to include direct links to these sections on the page. Hopefully in the past we haven't just dumped you on a page and said, go find it. I try very conscientiously to put the actual section link in the emails to follow up so that you don't have to go hunting for things. But if you don't mind, take a little bit of time to live with this new arrangement. It's kind of like rearranging the furniture in your house. This is a living, breathing space. So we will make updates on an ongoing basis. If you can't find anything, if you hate it, if it's frustrating, please do let us know kindly and gently, but let us know what we can improve so that it makes it easiest for all of you. We know you're busy, and we really, really appreciate the time that you take for this project. So we want to make it as easy as possible. Evelyn, do you have anything to add?
No, to your point, I think we want to just acknowledge this is a Confluence page, and we want to make it usable. Our focus has always been to be transparent with the work that we're doing and have these bring value to your initiatives as well. So please, we have received. We want to let you know we appreciate whenever you come back and say I cannot find this information or share this. And Lynette, I'd ask you to that point to talk about the FAQs.
Oh, yes. We've gotten many similar questions regarding the same types of things. So we are busy putting together a frequently asked questions list that will have answers and links to resources that either directly answer your question or to documents that you're looking for, or scope questions. And I think this will help in two ways. This will suggest that if you have questions regarding the project itself, for instance, what's the background, what's the scope, why did you choose these 3 domains, FAQs will be where you can look for those types of answers. And we know that many of you are still helping us recruit other stakeholders, and if you pass this information along to anyone else, it will be very helpful for them as well to have that resource. So we are in the midst of setting that up, and we will send you links once that is live. And I think at this point we just need to recap what the homework is.
Yep, let me go back to my share content. Sorry, bear with me as I bring up the PowerPoint slide again. Okay, so this is gone through here, and there we go. Homework.
Okay, so your next steps, your mission, shall you choose to accept it, our fearless stakeholder group, is to join the project if you have not already done so that we can keep in touch with you and so that you can receive updates, such as the link to the new FAQ page. Take some time if you want to submit data element concepts and data elements and codes. Go ahead and download that data element submission spreadsheet and fill it out and send it back to us. We have some time for that. Like Evelyn said, we will kick off the food insecurity domain discussions in mid-July. So you can send us your data element submissions anytime before that. And if you want to send in all 3 domains, that's fine. If you only want to focus on food insecurity, that's fine too. And then we would also ask that you review the patient story and the use cases, which there will be links posted shortly on Confluence for you to look at that documentation, and send us your recommendations or revisions, your comments, your feedback to gravityproject@emiadvisors.net.
And I'll just add.
Okay, go ahead.
Yeah, I just want to add that although the patient stories and use cases are in this PowerPoint slide, we're going to actually publish the Word document with it, so it'll be easier for you to just send us your comments via track changes.
Yeah.
So that would be really helpful for us as we move forward, and then we will aggregate it. So if you do have any thoughts about it, please send your homework by Tuesday, close of business.
Yes. And I think we have about a minute and a half. If anybody has any questions, feel free to chat or jump on the line. I'm watching the chat. Okay, everybody has their marching orders. We will go ahead and adjourn this afternoon. We look forward to getting your feedback. And we have one more question. Are the ICD-10 social determinants of health codes reimbursable at this point? This is from Stephanie Schroeder. Caroline, can you answer that question?
Some are, yes. Do we have the payer? Oh, no.
Oh,
no.
Stephanie Franklin says no, not at this time. Well, we may change that down the road, but we have work to do between now and then. So with that,
I think no.
go ahead, Evelyn.
Oh, no, some of the things, yes. I think I do want to acknowledge that there are, I know at the state level, they've been looking at what codes to reimburse, or not even from a reimbursable, but they're requiring practices to report out on certain codes. So, Stephanie, you have both no and yes. So, I don't know if you want.
Oh, yes, yes to the goal for reimbursement. Yes.
Okay, okay.
Yeah, we have big picture thinkers on the call here. I love it.
Okay.
Yes.
All right.
Okay. Well, go ahead, Evelyn. I will let you wrap us up.
Oh, no, thank you all, everyone. I appreciate your patience hearing my voice for most of the call. As we move forward, we really do need to have more interaction. It's just, these are the first couple of weeks is really walking through these, and that's why it's really important to send us your feedback and your thoughts. And again, thank you again to those who have submitted their data elements to date. One more plug about your data element submissions. If you are working within a large organization or state, we encourage you to reach out to your stakeholders to determine what they're collecting right now and perhaps plan that out internally and then consolidate and submit your data elements. And please ask us questions regarding that if you are unsure. That's what we're here for. Thank you, everyone.
All right. Thank you all.
Okay. Bye-bye.